our next guest speaker, Dr. Walsh, who will present his lecture about cardiovascular implications of PAH.
Swallow the microphone. Wait a minute.
Thank you.
Sorry, I'm not used to holding this. I should get a workout. I should make it weigh 10 pounds or something. Maybe I get a workout while I'm doing this. So we're hitting kind of BPD kind of hard, and so there's a little bit of overlap, and I apologize for the overlap, but we're actually sticking pretty true with adult educational principles, meaning that a lot of times you have to hear things 3 times before you remember it. And so I'll probably hit the 3rd time today, or this lecture, and so we'll move forward. You guys may have heard that I got a little bit of snow right before coming here, and so this is our back window. We had about a foot of snow when right before I left, and it's that really heavy, wet snow, and it sticks, and then in Boston, because I live near the ocean, it also blows quite a bit, and so it blew it up against this door. My wife sent me this picture going, how am I supposed to get out of here without you? Because I am the artificial snowblower in our house, and so I'm the one that actually moves all this stuff, and so I told her just to use the other door. I mean, that seems like a reasonable situation. And then I have to thank my team that met me at the airport quite late over and those types of things, and they took me to a nice American restaurant called Pizza Hut, and I got me a good pizza, which is what I needed after that long trip, and bought a few clothes and some necessities so I could get through the night and wake up, and so they were my lifesavers, and so I appreciate you guys. All right, so we're going to go over BPD and kind of the cardiopulmonary implications of BPD, because something that I struggle with a little bit in my profession is that we get so focused as respiratory therapists on the lungs that we forget kind of the heart. And a lot of times you can't talk about the lungs without the heart, particularly in some of these chronic lung diseases. And then also find ourselves as respiratory therapists is the negotiator between the neonatologist and the cardiologist, because the cardiologists go, it's not the heart, and the neonatologists say it's not the lungs. And then we end up having to go in between and going, it's probably a little bit of both of y'all. So let's get together and come up with the best plan. But obviously, preterm birth rate is significant, roughly 10.6%. That in the U.S. is kind of around 35,000 preterm births per year. It actually has a substantial mortality and morbidity with it. Obviously, the older you get or the more you weigh, those types of things, your mortality improves. Morbidity and mortality decrease, survival improves. And it's something that we have to relate to, because you wonder why some of these kids, and I've had some of the experiences that Natalie was talking to you about, I've had twins, triplets, those types of things, probably the closest genetic that you can come to of being the same, but yet many of them have different outcomes. One will develop BPD, one will not. And it's always made me kind of become interested in what causes BPD and those types of things. Obviously, it's more prominent in the very low birth weight population, and so that's something that, once again, you guys have seen. Kind of just summarized it for you here. I changed my screen, the backdrop to black, because it looks like I was giving you guys like a suntan up here when I had the white, and then someone I saw actually pull out their sunglasses. So I'm trying to change to help you out a little bit, and so I thought it was kind of funny to watch you guys. I love watching audiences when I speak, and so, but it's pretty significant. And so obviously if you're in that 750 to 500 gram age, 46% will likely develop BPD, and that roughly affects 14,000 preterm infants a year. And so highly significant, something we have to think about and contributes to the cost of their care. Obviously, bronchopulmonary dysplasia has many terms. As Natalie mentioned, chronic lung disease is sometimes another term. Another thing that we're actually starting to figure out, particularly in the older infant, and typically get into toddler age, is idiopathic pulmonary fibrosis is another thing that's starting to come along. And sometimes being born prematurely confuses it because we assume that you have BPD. But it comes to find out you have this idiopathic pulmonary fibrosis. And so because we're resuscitating and keeping alive and discharging so many more babies than we used to, we're starting to see confounding pictures that can confuse the situation. There's many terms for the definition, but typically at 36 weeks gestation, corrected age, persistent respiratory signs and symptoms, need for supplemental oxygen, and abnormal chest x-rays are typically indicative of BPD. And this has been manipulated, as you guys are aware, around that. So, for example, if you're on CPAP, but you're not on oxygen at this 36 weeks gestation, what do you have? And so people have kind of manipulated that. Some people will say, no, they don't have BPD because they're on room air, but they're still on significant support. Nasal CPAP of 5 or even bi-level type of mechanical ventilation, but they're not on oxygen, or they're on high flow nasal cannula at some extraordinarily high flow rate, but on room air. And so I have to think about some of those things as we move through. Everybody's seen these chest x-rays. I guess I should keep moving on because Natalie warmed me up. She actually showed MRIs and CTs and those types of things in much prettier pictures than I can show. So I'll have to one-up her next time. And so obviously BPD have increased risk of postnatal mortality. The rates of hospitalization are high. Other things that have been associated with BPD is asthma, emphysema. As Natalie was saying, is that we're now becoming of an age in which we are seeing these kids grow up to be adults and even older adults, and their incidences of COPD and those types of things are starting to be studied and looked at. And so we're trying to figure those things out as we move along. Pulmonary hypertension is what I'll talk about, cardiovascular compromise, malnutrition, and growth failure, cognitive impairments, cerebral palsy, neurodevelopmental deficiencies, and those types of things have also been associated with BPD. So let's kind of get on to the effects of cardiovascular of BPD. The pulmonary circulation, obviously it's been associated with pulmonary hypertension, or cor pulmonale is kind of a term that is often used in adults, right ventricular hypertrophy, aortic pulmonary collaterals, and those types of things. Systemic circulation problems have been associated with systemic hypertension and left ventricular hypertrophy, and it's something that we've seen in the past. This is actually a picture of a patient that we actually had who died from a pulmonary hypertension crisis in which we could not resolve, likely due to the VSD, which was unfortunate that this child had, that we could not feel comfortable or safe enough to actually repair. And then we'll talk about whether we should have done that or not in someone who's in a pulmonary hypertension crisis at that particular time. And so we have to think about it a little bit, but you can see that this musculature is very thick on both sides, and it's something, and had high voltages on the anterior precordial leads of the EKG. So let's dive a little deeper into pulmonary hypertension. When we think about pulmonary hypertension, there can be problems with hyperoxia, inflammation, ventilation, and infection. I think a lot of times we're getting hyperoxia and ventilation under control, but then sometimes we struggle with infection or inflammation. We have this immature lung circulation. It really kind of breaks down to 3 different types of problems that we often see. One's related to structure, one's related to function, and then growth. And a lot of times, remember, we want growth to help us. It often helps us with lung disease, so a lot of times we think it may actually help us with the pulmonary vasculature as well. And there's things that we do or don't do that affect that. So pulmonary hypertension in BPD, the prevalence is really unknown. And so I've kind of searched the literature and I can't really find a good enough review article or even studies that have actually looked at this. And I sometimes wonder if even if they did provide me evidence of what the pulmonary hypertension rate was, I wonder if some of it doesn't go undiagnosed. So in other words, we chalk it up to their chronic lung disease or BPD, and they actually have an underlying pulmonary hypertension on top of that. It's associated with dramatic increases in mortality, and then the predictors have been small for gestational age and severity of lung disease by Dr. Kahneman. Dr. Kahneman did this study of 42 infants in Boston, where I am, and looked at pulmonary hypertension and BPD, and it has a really high mortality rate. And so if your patient has been diagnosed, a lot of times you can see that their probability of survival drastically reduces just months after diagnosis for pulmonary artery hypertension. And if you have severe, it's even worse. So you have basically a 50% mortality rate here, like 76% mortality if it's not severe. But if it is severe, it drops to about 30% survival rate overall. And so something that's quite significant if you do have the opportunity to diagnose them with pulmonary hypertension. So when we talk about the definition, unfortunately, we're still working with an adult definition of pulmonary artery hypertension, and so it's often listed as 25 millimeters of mercury or 30 during exercise, and it's inadequate because it's really an adult definition. There's no relation to systemic blood pressure, and typically it has to be an invasive measure, and so a lot of times we don't have the opportunity to get invasive measures. Particularly in our neonates, and so no unified definition of pulmonary hypertension that I've been able to find in pediatrics. And so I know people are working on it, and so it's something that we often think about. Often it's diagnosed by velocities through echo of the tricuspid regurgitation, as you can see here, and it's something that we can do fairly easily. And so it's non-invasive, and it's something that we can get through. It is, however, not as precise a lot of times, and so we'll talk a little bit about that in a minute. Some people look at the septal configuration, whether it's normal, is it round in systolic, is it elevated but less than 50% systemic blood flow, or blood pressure, sorry. Is it flattened in systolic, or is it greater than but less than 100%? So you can see it's fairly subjective a lot of times when the cardiologist is reading this, or is it bowed into the left ventricular space, meaning that's greater than 100% systolic blood pressure. And so when we think about screening for pulmonary hypertension, there's really no guidelines to help guide us. A lot of times we just have to use our cardiology colleagues' expert opinion about the prevalence and specific risk factors, like when do you screen, how do you screen. A lot of times they may start with an EKG first because that's pretty benign, that's pretty cheap to do, and those types of things. And unfortunately, this lack of consensus may have important clinical implications, meaning that we might miss it or delay the diagnosis. So let's talk about what's screening who. A lot of times is that we often think about extreme prematurity, so less than 25 weeks, or birth weight less than 600 grams. Small for gestational age, once again, as I mentioned before, has kind of been associated with pulmonary hypertension, cause and effect, I don't know, those types of things. But prolonged mechanical ventilation is also in some patients in which we just have a failure to wean, or we just can't get them off, or they seem to have these rapid drops in saturations. And so oxygen requirement kind of out of proportion to severity of lung disease. Again, unfortunately, it's very subjective, so it's you looking at a chest x-ray and going, or compliance on the ventilator and those types of things, and going, it just doesn't seem like you should have that big of an oxygen requirement. And that may be good enough, but it's something we have to think through. Poor growth despite adequate caloric intake is another one that you may want to say you should screen for pulmonary hypertension. Screening and diagnosis is unfortunately just about as difficult as who you should to screen a lot of times. And as I mentioned before, EKG is relatively benign, and it may be something that is helpful, but unfortunately it's not very sensitive. And so, up to some of the studies that I read, it's up to 67% of patients might actually be missed because of that. And so, echo is another way. As I mentioned before, it's pretty non-invasive, but it may be subjective to the TR a lot of times, even who does it. So often the tech, whoever does the echo, and whoever the cardiologist is that reads it, often we try to keep them to be the same. And so if they're following someone longitudinally, we try to make those people be the same often, so that their technique and those types of things can actually be similar as best as possible. Often that's not allowed because of schedules or something like that. And then we also rule out other cardiovascular abnormalities, left to right shuts, pulmonary vein stenosis, kind of the typical things that you would think of, is particularly if they have an oxygen requirement that is just out of proportion to what they should be doing. And then we do have a cath lab, and so we have the option of doing catheterization. I know it's a lot easier for us who work in a large children's hospital, but a lot of neonatologists or NICUs don't actually have the capability of taking their patient to the cath lab or being the cardiologist to take them. But it can be done. But even us, we tend to reserve it for the severe pulmonary hypertension because it is fairly invasive, and it's something that we reserve for kind of the severe pulmonary hypertension kids, in which we kind of confirmed about echo and EKG. And then we can also take them down there to rule out additional cardiovascular abnormalities, and we can perform oxygen and nitric oxide challenges. When we do take them to the cath lab, you can see that in these 13 infants, a lot of times you have some responders and some non-responders. And so I always find it interesting is that, and I love kind of what I call dirty data, meaning you have patients who are humans, they often do different things. And so you have one patient here that from room air drops exactly the way you would expect them to. If you put them on 100% oxygen, they drop even further when you put them on nitric oxide and oxygen. But then you have this little guy over here who basically says, I'm going to defy all the odds, and I'm actually going to go up and have more pulmonary hypertension when I'm on oxygen, and then I'm going to drop when I'm on nitric oxide. But for the majority, you can see that many of them drop in parallel with the amount of oxygen or vasodilators they are getting. And so it's something that we can actually do to see if they will respond. So treatment is something that with severe pulmonary artery hypertension, you can increase their chances of survival by being fairly aggressive with treatment. Less severe, treatment can often minimize their exacerbations, morbidity, while supporting pulmonary growth. And then, as we often say, is a tincture of time. In other words, a lot of times we hope that they will grow out of this, or we hope that they will continue to vascularize and focusing on their pulmonary growth is important. Other treatments, obviously you would kind of exclude the causes of hypoxemia. So if they have obstructive sleep apnea, if they have central apnea, obviously those types of things, those waxes and wanes in oxygenation are something that you want to try to prevent, because if their pulmonary vasculature is twitchy, as we would say, you don't want to give them any more cause for making it clamp down and then them arrest or get bradycardia. Obviously, pulse oximetry is fairly cheap and can certainly be used as a screening tool to help eliminate that. And we even do that in their neonatal ICUs. That will kind of do an informal sleep study to help rule out whether they're actually having obstructions and try to help prevent this type of compromise. Remove left to right shunts. And this is something that I put as kind of the third bullet or the last bullet a lot of times is, we certainly want to potentially look at for aortic to pulmonary collaterals, VSDs, ASDs, and PDAs. But we often say it's better to be blue than gray. And what I mean by that is that if you have somebody who's got extreme pulmonary hypertension and you close one of their pop-offs, like a PDA or a VSD or an ASD, they will turn from blue to gray, meaning they won't no longer live often. And so we're very careful and we make sure that we have a lot of data saying that we think in our experience that we can close your PDA in the face of this pulmonary hypertension and not lose the whole heart, if you will, by doing such things, or an ASD or VSD. And so it's something that, like I said, we kind of jokingly say, but we take very, very seriously that before we do an intervention in someone who has pulmonary hypertension, we want to make sure that it's in their best interest. So further treatment, obviously home oxygen. These are things that we have to think about as neonatologists, that some of you guys may follow them up in clinic, and we have to think about how to keep their oxygen saturations and what is the appropriate range. And so patients who have documented pulmonary hypertension, we like to run their sats a little bit on the higher side, so greater than 95%. For those who are at risk for pulmonary hypertension or have mild pulmonary hypertension, we kind of lower the standard a little bit to 92 and above. And then we often remove it gradually. So they'll wean them, watch them in clinic for a little while, even do a pulse oximeter recording at home, have it downloaded so that we can see how many times they drop, what kind of their average sat before continuing to push the envelope. We certainly want to get them off of oxygen as soon as possible, but not if it's going to negatively impact them. Obviously, we have our assorted pulmonary vasodilators. So nitric oxide, as Natalie says, a lot of times you can't go home with that, although sometimes we have sent patients home with nitric oxide, believe it or not. We prefer to use, obviously, the things that we can send them home on, calcium channel blockers, PDE5 inhibitors like sildenafil, endothelium relaxing receptor antagonists like bocetin. And then we also have prostacyclines, and that's something I'll talk to you a little bit more about tomorrow, I believe it is, when we talk about aerosol or inhaled medications. But some of the prostacyclines are showing a little bit of promise. And then serial echoes to help evaluate the effectiveness of those therapies. We often do not just add these and then blindly say, come back in a year, 2 years. We often follow them up pretty quickly to make sure that our intervention is appropriate and that it's actually working. Otherwise, if it's not working, we try to get it off and start something else that may work. But unfortunately, there's no recommendations on the frequency either. That's just our practice, is that we tend to follow them a little bit closer than normal, and something we have to think about. So pulmonary hypertension, there's obviously 3 types of pathways: the endothelium pathway, the nitric oxide pathway, and the prostacyclin pathway. And it's something that we tend to look at. In fact, one of our boards, we actually have this to think through sometimes. How do we treat this? Are we treating this side? Are we treating the prostacyclin side? Are we treating the nitric oxide side? And then I'm going to kind of end with a few things about left ventricular hypertrophy. And so we've obviously had NFL players who were on steroids and those types of things end up having left ventricular hypertrophy, and I wonder if our patients sometimes aren't the same, the ones that need chronic steroids. And this is always a risk that we run with these patients, is that they can actually have that. And it's something that has been associated with steroid use and systemic hypertension. And so it's transient. It often resolves without cessation of steroids. With cessation of steroid treatments. It's uncertain whether it's clinically important or it's just a side effect type things, but maybe a cause of recurrent edema and chronic lung disease. And typically, no treatment is required. When it comes to systemic hypertension, a lot of times it's fairly common, and so we see that there are basically 4 different types of causes there that we tend to think about when it comes to systemic hypertension. Typically it's mild, and sometimes it even goes unrecognized by the pediatrician in the outpatient setting because they'll attribute it to the infant being active, crying in an unfamiliar situation, but it's something that we definitely have to get under control and make sure that we do have a normal blood pressure or not in these kids with BPD. And so they respond to pharmacological treatments such as calcium channel blockers, ACE inhibitors, and then you also need to rule out renal vascular disease or urinary tract disease by doing an ultrasound often. And then you can also do an EKG, as I mentioned before, to rule out left ventricular hypertrophy. So kind of in conclusion, pulmonary hypertension prevalence is unknown in BPD, sadly. It's associated with a high mortality, and so there are no established guidelines for screening or treatment. Pulmonary growth, definitive therapy is probably the thing that we have to do. And then other kind of cardiovascular effects associated with BPD are fairly common, but they're often relatively benign. Left ventricular hypertrophy resolves once we get them off the steroids, and then hypertension needs to be ruled out through other abnormalities that we may think about. And then I'll be happy to take any questions that you guys may have.
Thank you very much, Dr. Brian, for this excellent lecture. And I think we prefer to postpone the questions till the end of the next